Hi guys, welcome to the high yield review for the Derm module. This review is set up as a matching game, and I'd recommend that you pause when you see a slide without the answers, try to answer it first yourself, and then unpause when you're ready to hear the answers. Okay, let's get started. We're going to start with some pathology. Okay, there we go, pigmentation disorders. So pause and then unpause when you're ready to hear the answers. Okay, freckles. So if you guys remember, freckles, they're seasonal, right? They can come and go. With freckles, the number of melanocytes stays the same, okay? The only thing that's increasing is the pigment within the melanocytes. Lentigo are slightly different than freckles. Even though they might look like freckles, they're actually more permanent. They don't just come and go. And we do see an increase in number of melanocytes in lentigo. So we do see melanocytic hyperplasia, but it's more linear. So you can see a more linear, non-nested melanocytic hyperplasia. Number 3 is a compound nevus. So compound nevus, anytime you see nevus, you want to think of more nested melanocytic hyperplasia. So it nests like that. Okay, so in a compound nevus, you're going to see these nests of melanocytes at the epidermodermoid junction and also down in the dermis. Number 4 is a dysplastic nevus, so you're starting to see some dysplasia, right? So what you're going to be seeing is both nested and non-nested hyperplasia of atypical melanocytes. So you're starting to see the dysplasia, right? And this is a precursor of melanoma. Number 5 is melanoma. I think one of the most important things to know about melanoma, or one of the most high yield things that they ask on the exams, is the mutations that are involved with melanoma. So you want to remember that if it's sporadic, it's BRAF is the most common one. However, if it's a familial melanoma, it's either CDKN2A or your P16-INK4A mutation. So what are you going to see in melanoma? On histology, it's going to look just like a dysplastic nevus. The only addition to that is going to be metastases to brain, the heart, and the liver. Okay, so moving on to tumors. So take a minute, try to answer these, and then unpause when you're ready. Okay, seborrheic keratosis. So seborrheic keratosis, there are those old age plaques that we see on, older people's back, or mostly back, right? So these are horn cysts containing keratin on histology. So you're actually going to see these cysts that are filling up with keratin. So horn cysts containing keratin, old age, velvety, stuck on plaques. They can, however, happen to younger people, and that's when you want to think of a possible GI tumor, because they show up as a paraneoplastic sign involved with GI tumors. So if some young person comes to you with a lot of horn cysts or these seborrheic keratosis, you want to think about GI tumors, and this is called the lesser Trellat sign. Okay, number 2, actinic solar keratosis. I just like to say actinic solar keratosis elastosis. It kind of rhymes, and that's actually what you see on histology is elastosis. So you see elastosis, cytological atypia, and it's a very sandpaper-like consistency and seen in sun-exposed areas. Number 3 is our squamous cell carcinoma. This has to do with our p53 mutation. And who are some people who can develop squamous cell carcinoma of the skin? People with actinic keratosis. So actually actinic keratosis or actinic solar keratosis elastosis can progress to a squamous cell carcinoma. Other UV radiation, kids or people with xeroderma pigmentosum, tobacco use, and very importantly, people undergoing chemo or immunosuppressed are also prone to developing squamous cell carcinoma of the skin. Okay, next is our basal cell carcinoma of the skin. What you want to remember is the classic histology. Nests of basaloid cells with this peripheral palisading that you can see here. And this is most commonly associated with our xeroderma pigmentosum or nucleotide excision repair defect, most commonly, and then also can be seen with some PTCH and some P53 mutations. Okay, moving on to dermatofibroma sarcoma protuberans. So fibrosarcoma protuberance, right? So a lot of things going on. And this is what we see. It's a nodule, usually on the trunk, and we see the storiform type. If you see this, these cells are kind of making a star in the center, so a storiform pattern on histology. And it's usually a collagen 1A1 or a PDGF beta mutation or defect. Okay, and the last one is our mastocytosis. So mastocytosis, we actually see a lot of mast cells. So increase the number of mast cells, they give you a lot of pruritus, all that histamine release. So what you're going to see is you're going to see metachromatic granules in cytoplasm. Those granules are just representing those granules that store the histamine within the mast cells. And you're gonna have pruritus. You're gonna see a Derrier sign, dermatographism. Like if you draw on their skin, if you just like rub your nail on their skin, you're gonna see like this red, pruritus, this whole mark that it leaves behind. Okay, moving on to dermatoses. So pause and unpause when you're ready. Okay, so urticaria or hives. Well, that is our angioedema, right? Allergy. You're thinking more allergy, angioedema. So you're going to see a lot of dermal edema, sparse lymphocytes, dilated lymph, and vascular spaces. So it's not really a lymphocyte problem, right? It's more of like an edema, dilated lymph, vascular spaces. And you're going to see this with allergies, angioedema. Number 2 is atopic dermatitis. So usually people who present with atopic dermatitis also present with wheezing and a history of asthma. It's usually young kids, like 2 to 5 years of age. Okay, the rash, the atopic dermatitis rash, it's a type of eczematous rash, which is red, vesicular, oozing crusted lesion. Okay, so if they have eczema, along with a history of asthma and wheezing, it's going to be atopic dermatitis. Okay, so what you're going to see on histology with atopic dermatitis is spongiosis. And with time, it can progress to hyperkeratosis, acanthosis, or parakeratosis. But spongiosis to begin with. Number 3 is our Stevens-Johnson syndrome. With Stevens-Johnson, it's a type of erythema multiforme. You see your target lesions, okay? And what you're going to see is apoptotic keratinocytes and interface dermatitis. This is a type of hypersensitivity reaction. You see CD4, CD8 T cells. The other type of erythema multiforme is TEN, or toxic epidermal necrosis. The difference between Stevens-Johnson and TEN really is how much mucosal involvement. If it's less than 10%, it's Stevens-Johnson syndrome. If it's greater than 30%, I believe, or greater than 10% or about 30%, then it's your toxic epidermal necrolysis. Okay, number 4 is psoriasis. Psoriasis is going to be your option A. You're going to see this comb teeth-like appearance on histology. You're going to see hyperkeratosis, parakeratosis, acanthosis, Monroe's abscesses, little neutrophils collecting under these comb-like structures. You're going to see a positive Auspitz sign. Auspitz sign is basically if you pick on the lesion, if you try to peel it off, you're going to see blood. It's going to bleed. Also associated with psoriatic arthritis, some nail changes. Cobner phenomena is if you basically take normal skin and you scratch it or with your nail or something, or cause any kind of like injury, you will see a new lesion develop. That's Cobner's phenomena. Okay, and then lichen planus. Lichen planus is option C. Remember your 6 P's of lichen planus, which are your pruritic, purple, polygonal, planar, papules, and plaques. Okay, what you're going to see on histology with lichen planus is this sawtooth pattern. Okay, and it is positive for Cobner's phenomena, so you can get new lesions on normal skin. However, these do not bleed, so it's negative for Auspitz. And what you're going to see are band-like infiltrates at the dermo-epidermoid junction, hyperkeratosis, hypergranulosis, and some civet or colloid bodies. Okay, and you're also going to see some Wickham striae on gross appearance, these little gray lines that run through the lesion. Okay, so that's the dermatoses. Moving on to some blistering diseases. So pause and unpause when you're ready. Okay, so pemphigus vulgaris, right? It's your IgGs against desmogleins. Okay, these are positive for Nikolsky sign. What Nikolsky sign means is basically if you press on these blisters from the sides, they're going to slough off. So if you press on this from the sides or more from laterally, it's actually going to slough off and you're going to see the blister like come off your skin. So that's a positive Nikolsky sign. They're very fragile blisters. And what you see on histology is acantholytic cells. You see these little purple cells in between these tombstone like structures. So you can see a tombstone like structure and you see these acantholytic cells kind of stuck in between them. This is a suprabasal blister. And on immunofluorescence, you're going to see a fishnet pattern of your IgG deposits. Okay, moving on to bullous pemphigoid. These are very tense blisters, okay? And these do not slough off. This is a negative Nikolsky sign. You see IgG and IgG antibodies against hemidesmosomes or BPAG in this case. They are non-acantholytic, so you don't see any acantholytic cells, but you do see, a blister below the epidermis, so a subepidermal blister. And on immunofluorescence, you're going to see a linear deposition of your Igs. Also some increased eosinophils. And the last one is your dermatitis herpetiformis. Dermatitis herpetiformis, you see IgA antibodies this time against dietary gluten. So you're going to see this in someone who probably has celiac disease and gluten sensitivity. So the antibodies actually end up cross-reacting with reticulin, and they end up dissolving, anchoring fibrils. So what you get is a subepidermal blister, and you also see some microabscesses at the tips of the dermal papillae. On immunofluorescence, you're going to see granular deposits at the tips of the dermal papillae. Okay, and there's this, little mnemonic dam is a vulgar word, so pemphigus vulgaris. You have antibodies against desmoglein, you see acantholytic cells. There's mouth involvement with pemphigus, which you don't see with bullous pemphigoid. And Nikolsky sign is positive since they're very fragile blisters. Okay, so that was just a quick pathology summary. Now we're moving on to some microbiology. So pause and unpause when you're ready. So what I try to do here is just try to highlight, I guess, the high yield things that hopefully you recognize and you know what they're talking about, right? So for Staph aureus, scalded skin syndrome, and impetigo is pretty classical. And obviously osteomyelitis, one of the most common causes of osteomyelitis, and gangrene as well. Strep pyo, erysipelas is what you see with strep pyo, but impetigo is also something that you can see with strep pyo, along with some necrotizing fasciitis. Clostridium gives you myonecrosis and gas gangrene. Pseudomonas gives you ecthyma gangrenosum, folliculitis, and cellulitis. And then your Bartonella quintana gives you your bacillary angiomatosis. Okay, moving on to some fungal infections. So pause and try to answer when you're ready. So I do have a little classification of fungal infections for you. You have some superficial infections, then you have some cutaneous infections, subcutaneous, and mixed. Okay, so make sure you know how we classify these fungal infections before you start to answer these. Okay, so Malassezia furfur, you've seen with pityriasis or tinea versicolor. Remember, Malassezia furfur is yeast-like if you look at it under the microscope. And what you see with tinea versicolor is hypopigmented macules. Okay, it's one of the superficial mycoses. So going back up here, superficial tinea versicolor is a superficial mycoses. Okay, next is our trichophyton. Trichophyton is actually, so going back here, it's one of the dermatophytes in our cutaneous mycoses. So we can see trichophyton specifically, it says tri, so TRI 3. So it's associated with all three: skin, hair, and nails. We also have microsporum that only does skin and hair. and our epidermal phyton, which does only skin and nails. So make sure you know all three of these. Okay, number 3 is Candida, and Candida, going back here, is also cutaneous. So Candida gives you, your diaper rash. It can give you vulvovaginitis. And what it's going to look like under the microscope is pseudohyphae. Okay. Oh, and trichophyton was a septate hyphae. So make sure you know, because sometimes they might describe what they see in the microscope rather than give you the name of the type of fungus that they're seeing. Number 4 is Madarella. This is actually your subcutaneous mycotomas. Okay, and what you see with this is Madura foot. It's a subcu. We see sinus tracts open into the skin of the foot. And number 5 is your Fusarium. It's has some branching septae but no pigment. And we see this usually in immunocompromised patients. And what we end up seeing is some keratitis, eczema, and onychomycosis. Okay, so moving on to some viruses. So take a minute, and then when you're ready, you can unpause. Okay, so VZV is our varicella, right? And sorry, one second. Yes, so VCV is our varicella zoster. It's a double-stranded DNA enveloped, and we're going to see our papules, pustules, crusting vesicles all at the same time, right? So that kind of gives away your varicella zoster. Okay, and then number 2 is your measles rubeola. Measles rubeola are your negative single-stranded RNA enveloped viruses. And what we see with measles is something very interesting. We see Koplik spots, which are enanthems. They're in kind of like the oral mucosa. And they start out just little spots in the oral mucosa and then spread out on the skin. So we start with enanthem, and then we spread out to the skin as macules and papules called exanthem. And then eventually either you recover or you can also progress to encephalitis. Okay, number 3 is HHV6 or 7. This is your double-stranded DNA enveloped. And what you see with HHV6 and 7, you see high fever. Seizures is really big with this one. So you're going to see seizures and encephalitis. And since it's part of the herpes family, this is also going to be your double-stranded DNA enveloped. Okay, number 4 is your parvovirus B19. It's a single-stranded DNA. It's very, very small. And this is the one that gives you your classical slap cheek rash appearance and severe aplastic anemia. Okay, number 5 is molluscum contagiosum. This is associated with the pox virus. It's actually the easiest to identify out of all of these because this one is not red. It's actually pearly gray or a wart-like lesion. And this is a pox virus. It's a double-stranded DNA enveloped, a brick-shaped virus. Okay, moving on to some zoonotic infections. So pause and unpause when you're ready. Okay, so Francisella grows on cysteine-rich media. That's how they usually like to describe this in the question stem. And this gives us rabbit fever. Coxiella gives us Q fever. And remember, it can spread through placenta of, cows and cattle. And what you see with Q fever is subacute endocarditis. Okay, number 3 is Leptospira. Leptospira is a spirochete. It has 2 endoflagella. And Leptospira is interesting because it actually spreads through water. So the rat is going to pee in the water, and from the water it's going to get picked up by dogs or humans. The disease that we see with Leptospira is called Weil's disease. It's an icteric disease, and it can affect the liver, the kidney, and bone marrow. Number 4 is Yersinia pestis. Yersinia pestis is plague, right? And plague, what we see really classically with Yersinia is these things called buboes. They're necrotizing lymphadenitis in the axilla and the groin. Okay, and then this is just really important. I've also seen this been asked in UWorld quite a lot of times. So Yersinia pestis is plague and associated with bubo. And Bacillus anthracis, it's our wide, we can see the wide mediastinum, and hemorrhage in inhalation anthrax, which is spread through spores. Okay. And yeah, and Bacillus is also one of the bioterrorists along with Yersinia. Okay, moving on to some pharmacology slides. So pause and unpause when you're ready. So this is a little, summary sheet of the drugs that act on fungi. I went in and added some things that were kind of missing. But you can see here, there's drugs that act on the cell membrane. There's drugs that act by blocking nucleic acid synthesis. There's drugs that act as cell wall inhibitors. And there's drugs that disrupt microtubule functions. Okay. So yeah, hopefully this is relatively easy to remember the functions for each one of them. So number one, binds or gostrol and forms spores in the cell membrane. This is your amphotericin B. This is part of the polyenes group. Okay, number two, swish and swallow and used for oral thrush. This is your nystatin. Number three, inhibits squalene epoxidase. This is your terbinafine. Okay, and number four, CYP450 inhibitor. This one is your fluconazole. Your azoles tend to be your CYP450 inhibitors. Number five, used for dermatophytes infection, pregnancy category X. This is your griseofulvin. And inhibits cell wall synthesis. For the cell walls, we have our fungins, so micafungin, for example, or caspofungin. Okay. Take a minute to answer these, and then when you're ready, unpause. Okay, so used in severe recalcitrant acne, avoid in pregnancy. This is your F or isotretinoin, and because this is teratogenic, so avoid it in pregnancy. You actually ask someone to take a pregnancy test before you start the woman on isotretinoin. Okay, number two, used for psoriasis and is a vitamin D analog. And this is, one of the very good treatments we have for psoriasis, and that's our calcipotriene. Number three, inhibit the release of IL-2 and used for atopic dermatitis. This is our tacrolimus. Number four, inhibits bacterial lipid carrier bactoprenol. So that's our bacitracin. Number five, used for HPV, actinic keratosis, and superficial basal cell carcinoma. And this is our imiquimod, which is a TLR7 agonist. It actually improves or enhances the immune system to, fight the infection better. Number six, a topical drug used for Kaposi sarcoma, and that's your alloretinoin. Okay. I believe this is the last slide, so pause and unpause when you're ready. Okay, there we go. So angina, heart failure, and hypertension, we use hawthorn as one of the alternative medicines. Benign prostate hyperplasia is saw palmetto. Sprains, strain, ecchymosis, arthritis is arnica. I've actually used this myself, and it does sort of work. And UTIs, there's cranberry. Everyone's tried cranberry for UTIs. Cranberry juice, right? And then varicose veins, there's horse chestnut seed extract. For liver disease, there's milk thistle. And I think one of the most important ones that I've seen in New World and more commonly tested on STEP is St. John's wort. It's a drug to treat moderate depression, some seasonal affective disorder, mild anxiety, kind of like a good drug for mental health problems. And what you want to remember is it's a CYP450 inducer. So it's an example of one of the alternative medicines that can actually interfere with our more allopathic medicine. So remember St. John's wort. Okay, and that is all. Thank you for your time. Hope you enjoyed this review. Thank you.